Obstructed labor. Comprehensive overview. Obstructed labor, also known as labor dystocia, is the baby not exiting the pelvis because it is physically blocked during childbirth. Although the uterus contracts normally, complications for the baby include not getting enough oxygen, which may result in death. Obstructed labor is a failure of the presenting part of the fetus, head, shoulder, or breech, to progress through the birth canal despite strong, coordinated uterine contractions due to a mechanical or functional obstruction. It is a direct cause of maternal and neonatal morbidity and mortality, especially in low-resource settings. Causes: 1. Cephalopelvic disproportion, CPD, mismatch between fetal head size and maternal pelvic dimensions. 2. Malpresentations and malpositions. Brow presentation, face presentation, especially mento-posterior, shoulder presentation, transverse lie, occipito-posterior position with failure of rotation. 3. Fetal causes: hydrocephalus, conjoined twins, large fetus, macrosomia. 4. Pelvic abnormalities: contracted pelvis, due to rickets, malnutrition, pelvic fracture, deformities. 5. Soft tissue obstruction, cervical fibroids, ovarian tumors, full bladder or rectum. Risk factors of obstructed labor. There are several risk factors that can increase the likelihood of obstructed labor. One of the primary risk factors is a contracted or abnormally shaped pelvis, which can impede the progress of labor. Other factors include maternal obesity, previous difficult deliveries, prolonged labor, and certain medical conditions such as diabetes or high blood pressure. It's important for healthcare providers to identify these risk factors early on during prenatal care in order to develop appropriate management plans. By recognizing these factors, healthcare professionals can take necessary precautions and interventions to ensure a safe delivery for both mother and baby. Preventive measures such as proper nutrition, regular exercise, and maintaining a healthy weight can also help reduce the risk of obstructed labor. Additionally, timely access to quality obstetric care and skilled birth attendants play a vital role in detecting any signs of obstruction during labor and providing prompt interventions when needed. By understanding the risk factors associated with obstructed labor and implementing appropriate strategies, we can work towards reducing its occurrence and improving maternal and neonatal outcomes. Short stature and pelvic deformities, common in childhood, malnutrition or rickets, adolescent pregnancy, incomplete pelvic growth, grand multiparity with malpresentations, large fetus due to maternal diabetes or prolonged pregnancy, poor antenatal care, delayed hospital presentation, previous history of obstructed labor, pathophysiology, persistent strong uterine contractions against an obstruction lead to excessive uterine activity, uterine hypertonus, Bandl's ring, maternal exhaustion with dehydration and ketoacidosis, bladder and urethral compression edema, ischemia, fistula formation, risk of uterine rupture from overstretching, fetal distress due to prolonged hypoxia stillbirth if not relieved. Diagnosis for obstructed labor. Diagnosing obstructed labor is a critical aspect of ensuring the safety and well-being of both the mother and their baby. Prompt identification and intervention can help prevent complications and reduce the risk of adverse outcomes. Doctors employ various methods to diagnose obstructed labor accurately. One commonly used diagnostic tool is a thorough physical examination, which includes assessing the progress of labor, monitoring vital signs, and evaluating the position of the baby. In addition to physical examination, healthcare providers may utilize imaging techniques such as ultrasound to further evaluate the condition. Ultrasound can provide valuable information about fetal position, size, and any potential abnormalities that may contribute to obstructed labor. Also, continuous monitoring of maternal and fetal well-being during labor plays a crucial role in diagnosing obstructed labor. This involves closely observing vital signs, uterine contractions, fetal heart rate patterns, and other indicators that may suggest complications or hindered progress. It is important for healthcare providers to be vigilant in recognizing signs of obstructed labor promptly. by employing a combination of physical examination techniques, imaging technology, and continuous monitoring. Medical professionals can accurately diagnose this condition and take appropriate measures to ensure a safe delivery for both mother and baby. Clinical presentation. Prolonged labor with no descent of the presenting part. Maternal distress, restlessness, exhaustion, dehydration, fever, distended bladder, blood-stained urine. Uterus, tonic contractions, Bandl's ring visible or palpable. Fetal heart sounds, absent or abnormal, distress. Vaginal examination, molding. Caput formation, edematous cervix. Immovable presenting part. Complications. Maternal, uterine rupture. Postpartum hemorrhage. Sepsis. Vesicovaginal fistula, VVF, or rectovaginal fistula, RVF. Shock and death. Fetal. Hypoxia, acidosis, stillbirth. Birth trauma, fractures, nerve injuries. Prevention. Adequate antenatal care with risk factor identification, pelvic assessment. Fetal size, malpresentations. Nutritional support during childhood and pregnancy to prevent stunting and pelvic deformities. Discouraging early marriage and teenage pregnancy. Skilled birth attendants with timely referral systems. Use of partograph during labor to detect delay early. Community education on seeking early hospital delivery, especially for high-risk mothers. Control and management. Immediate measures. Admit to a hospital with surgical facilities. Establish four-line. Correct dehydration. Give fluids, oxygen if needed. Insert Foley catheter to drain bladder and monitor urine output. Broad-spectrum antibiotics to prevent infection. Monitor maternal vital signs and fetal heart. Definitive management. Depends on cause, condition of mother and fetus, and availability of facilities. Caesarean section, C/S most common and safest option. Symphysiotomy or destructive operations, rare. In resource-limited settings. If fetus is dead and CS impossible. Laparotomy for uterine rupture repair or hysterectomy if necessary. Resuscitation of newborn if alive. Precautions. Never attempt forceful delivery, forceps or vacuum, in true obstruction. Avoid excessive oxytocin augmentation as it risks rupture. Ensure blood is available for transfusion. Sterile technique during intervention to reduce infection. Continuous monitoring during and after intervention. Summary. Obstructed labor is a dangerous complication of childbirth, where the fetus cannot progress due to mechanical or positional barriers, despite strong uterine contractions. It leads to maternal exhaustion, uterine rupture, sepsis, and fetal death if not addressed promptly. The cornerstone of prevention is good antenatal care, skilled birth attendants, and timely referral. Definitive treatment is usually caesarean section, alongside supportive measures like fluids, antibiotics, and bladder care. Conclusions. Obstructed labor remains a leading cause of maternal and neonatal deaths, especially in low-resource areas. It is largely preventable through improved antenatal care, community education, and skilled obstetric interventions. Delay in recognizing and managing obstruction is the most dangerous factor. Action plan. 1. For women and communities. Delay age of first pregnancy. Promote adequate nutrition. Encourage skilled birth attendants and hospital delivery. Educate about early warning signs of prolonged labor. 2. For health systems. Ensure all labor wards use partograph for monitoring. Provide accessible, affordable emergency obstetric care. Train health workers in recognizing and managing difficult labor. Strengthen referral networks and emergency transport. 3. For individual cases. At first signs of prolonged or obstructed labor, immediate referral to hospital. Stabilize mother, for fluids, antibiotics, bladder care. Proceed to caesarean section or appropriate surgical intervention. Postpartum follow-up for complications, fistula, sepsis, anemia, psychological support. Remember, every pregnant woman must have been educated during antenatal care about the possible natural delivery or caesarean section.
If you find this video helpful, like, subscribe or follow My Health by Dr. J for more important health videos.